Yeah, yes.
Yes, it's okay to wait a few minutes while people arrive.
Okay. It's okay.
Great. Hi, Kadir. Hi, Ryan.
I invited some of my students to join this seminar.
Welcome, everyone. Do you want to just introduce their names as we wait? You're welcome.
Okay. I will introduce some of my students who is also who are also in this Zoom meeting. They are Miss Shu, Juntao Shu, Mr. Chunhu Li, and Miss Pei Yao Zhai, and Miss Qing Jiang, yeah.
Well, very welcome. You're very welcome to join us. We are very happy you are here today. Okay, what is it now? It's 2 minutes past. Maybe we can start just. I'll introduce you, Gang Qin. You're an associate professor in the Department of Epidemiology and Biostatistics in Nantong University School of Public Health. You serve as a senior consultant at the Department of Infectious Diseases in the affiliated hospital of Nantong University. And your primary research areas encompass infectious disease epidemiology, mathematical modeling, bioimmunology, and the study of emerging diseases such as TB, HIV, and COVID. He works on developing modeling frameworks that empower decision makers to utilize epidemiological data and making impactful choices. That sounds perfect. Dr. Qin has extensive experience across various study designs, including cohort studies, randomized controls trials, and modeling studies. And he also has knowledge in expertise in health economics. So a really fantastic researcher who is bringing together skills in data, getting new primary data, be they do cohort studies, observational studies, or randomized control trials, and then taking that further, using mathematical models to generalize away from the individual studies into the wider populations. And I think we have a really, really good example of that here today, in which Dr. Qin and his colleagues have taken the results from the really, really important Vaccae trial in China, which results were shown at the Union end of last year, and generalized the results to China to see what the population health and economic benefits and costs might be. So we're really excited that you are here, Gang Qin, and we're really looking forward to listening to your presentation and learning more about your work. Over to you.
Okay. Let me share the screen. Yeah. Good afternoon, Professor White, and distinguished experts and fellow academics. I'm pleased to introduce myself as Tony Qing from the affiliated hospital of Nantong University, China. It is both an honor and a privilege to be a part of today's seminar, where I will be presenting our research entitled population level health and economic impact of introducing Vaccae vaccination in China, a modeling study. The research will be discussed in detail through 6 fundamental sections: background, aims and significance, methodology, results, conclusions, and our noteworthy findings. China was the third highest tuberculosis burden country in the world as of 2021. The incidence of tuberculosis ranked the second among Class A and B infectious diseases in the nation, with mortality rates exceeded only by AIDS. Compounding the issue, China has a high burden of latent tuberculosis infection, LTBI, with studies showing that individuals individuals aged 45 and above account for 3/4 of TB cases. Considering the prevalent aging population issue, it becomes imperative to explore and implement novel prevention strategies. Thus, new combination vaccines have come to the forefront of the endeavor. Presently, the clinical development pipeline includes 16 TB vaccine candidates classified into 3 types. The first, pre-infection vaccine such as BCG. The second, post-infection vaccines like Vaccae. And the third, dual role vaccines that are both pre- and post-infection P and PI. Notably, Vaccae has completed phase 3 trial and boasts protective efficacy of up to 54.7%. Vaccae stands as the world's first newly marked tuberculosis vaccine, representing potential new strategic avenue in China's vaccination planning. This study seeks to evaluate the projected impact of a government-sponsored Vaccae vaccination program on the health outcomes and economic benefits for the population of China. The implications of this study are profound, providing a scientific foundation that could influence TB control policy, not only in China, but potentially for other countries facing similar challenges. I will now shed light on the methodology of our research. We employed an age-structured compartmental model developed using R software and informed by China-specific demographic and epidemiological data. Modeling included age intervals from 0 to 100 years, capturing the natural history of TB across 5 distinct states. Vaccae's mechanisms of action primarily focus on preventing disease progress by blocking reactivation or new infection in those with LTBI and reinfection or relapse in recovered patients. It's highlighted by the 2 red circles as depicted by the yellow circle. And figure 1b demonstrates the intricate age-structured compartmental model for TB's natural course and transmissibility, including all stages from uninfected through potential reinfection post-recovery. Now, the model calibration. Parameters employed for model calibration were extracted from various authoritative sources, such as the United Nations population projections, the Chinese tuberculosis sample survey report, and the China Public Health Science Data Center. The calibration process utilized the nailed-mid algorithm, and the top 100 calibration outcomes were subsequently selected for in-depth analysis. For vaccination strategy, our model presupposes Vaccae's wider scale availability by 2024, this year. Utilization of the GST with 77.2% sensitivity screens for ARTPI, and individuals tested as GST positive are assumed to fully accept vaccination. 90% vaccination coverage is posited, reflecting China's robust immunization infrastructure. Our cost analysis, considering perspectives from healthcare and societal at large, incorporates both direct and indirect costs alongside the vaccination program expenses. Particularly noteworthy, the model accounts for productivity losses attributable to TB-induced work absence or premature mortality. The health economic evaluation of the vaccine strategies using daily as an economic utility index, applying a willingness to pay WTP threshold and a specified discount rate for a monetary valuation. The health economic evaluation of vaccine incorporating a range of sensitivity analysis, including deterministic, probabilistic, and threshold examinations for vaccine pricing, allows for a robust evaluation of the proposed vaccine implementation economic viability. This component estimates adjustments to annual healthcare and societal budgets from 2024 to 2050, and calculates the cumulative net cost. I will proceed to elaborate on the results section. The model effectively aligns with the demographic and epidemiological patterns and offers a calibrated approximation of TB trends in China. According to our projections, the demographic patterns of TB incidence are undergoing a significant change, with a growing burden on the elderly population. From 46.8 in 2020, we expect to see a rise to 80.5% in 2050 among incident TB cases within the older demographic, which by then will represent 38.8% of the entire population of China. As a evaluation, as evaluation of vaccination strategies across varying age groups revealed that immunizing older adults is notably more effective for public health. Furthermore, as depicted in this table, in table 3, the incremental cost effectiveness ratio, the ISA, for routine vaccination, vaccinating older adults is exceptionally economic, below the threshold of 1 time the per capita GDP. Upon assessing the public health impact, we determined that a targeted vaccination approach among older adults is less efficient compared to a wider mass vaccination strategy. This figure 7b, clearly illustrates that the P&PI vaccine administered universally markedly diminished TB incident rates. When we consider cost effectiveness, the routine administration of PSI vaccine to the elderly shows remarkably economic advantages, particularly when the vaccine's protective span is estimated at 10 years. In scenarios where vaccine protection extends to 20 years, our findings show that although all mass vaccination strategies are cost-effective and lead to a reduction in daily compared to the status quo, the no vaccine scenario, the elderly specific routine vaccination remains the most beneficial approach. In this table, table 4 reinforces that with lifelong vaccine protection, the routine P&PI vaccination strategy for older adults stands out as the most cost-effective option. The results of sensitivity analysis, the tornado diagram, indicated that vaccine pricing significantly influences the ISA according to our one-way sensitivity analysis. Figure 8A through 8D signifies acceptable pricing models for the Vaccae vaccine, assuming a 20-year protection period. Hence, here the PSI vaccine demonstrates an advantage, tolerating a substantially higher price ceiling than the P&PI vaccine. Moreover, as shown in figure 8E, when the PSI vaccine is priced at $30 per dose, it holds a 100% likelihood of being cost-effective for the elderly. Using the 20-year PSI vaccine strategy for older adults as our case study, we observed that the majority of the program's expenditures is concentrated in its initial year, surpassing 10 billion US dollars in 2024. Over a decade, costs are projected to stabilize to roughly $400 million annually, occurring a net expense of 16.72 billion over the 27 years. Yes. Our study marks a pioneering economic evaluation of the novel TB vaccine Vaccae and vaccination strategies. It covers the potential impacts across various scenarios. Nevertheless, it does not take into account factors such as gender disparities, provincial heterogeneity, and multi-drug resistant strains. Additionally, it omits potential effects of immunogenic decay and changes in demographic policies. Our findings are threefold. Firstly, targeting vaccination towards the elderly emerges as an exceptionally cost-effective method for TB epidemic control in China. Secondly, reducing the cost of vaccines is imperative to ensure a favorable economic returns for future vaccination campaigns. Lastly, we also advocate for supplementary interventions to help meet the anti-TB strategy targets for 2035 and 2050. I'm pleased to share that our work has been featured in the BMJ Global Health Journal in last year, and I will I extend my deepest appreciation to our dedicated team for their contribution to this pivotal project. Also, I would also my thanks go to the two collaborating experts, including Professor White and Professor Li from the China Pharmaceutical University. I'm grateful for the platform to disseminate our findings and sincerely appreciate your attention. Should you have any questions or seek further clarification, please do not hesitate to ask. Thank you. Yes, Professor Y.
Yes, can I just be the first to thank you for such a great presentation of such an important piece of work. It's a beautiful piece of work, and it was beautifully, concisely presented. So we have lots of time for questions, which is fantastic. If you would like to ask a question and you're online, just please put your hand up. There's a few of us online, so it would be good just to see who might want to speak. And we can go ahead. Shall I kick off? I can either kick off with the kind of more technical questions, or I could kick off with the more kind of policy-related questions. Do you have any preferences, Dr. Chin? Or maybe I'll just ask a question. How about Actually, yeah, let's start off just by understanding the vaccine candidate itself and the programmatic challenges. One thing I wasn't totally sure about is I think it's licensed for TST positive individuals or infected individuals. I don't know how the license exactly says, but does that mean you have to screen before you give the vaccine, or is there enough safety data on TST negatives to be able to give it to anybody? You just would like to screen because you want to be sure you're vaccinating infected individuals. Is that question clear?
Yes. Thank you for your question. Vaccae is in the clinical trial. Vaccae is designed to vaccinating only the individuals who is TST positive and the chest X-ray is negative. So the TST screening is a prerequisite before the vaccination. There is no data concerning the TST negative individuals with Vaccae.
Yes, not even safety data.
Safety data is the safety data also is only in the individuals with LTBI. It's quite safe. There is no severe adverse events in the clinical trials.
Okay, that's very, very clear. Thank you very much. Do you put your hands up if you want to ask a question? Otherwise, I'll keep asking questions. We could then move maybe to couple of technical questions. I don't want to spend too long on the technicalities, but just maybe one or two. Your baseline scenario, as I think, assumes that the quality of care of other interventions didn't improve over time. Did you model a scenario where other interventions would improve in the future, or yeah, full stop?
Yes. Our background scenario or the status quo is the BCG, the routine BCG vaccination and the dots treatment, and they are intricate because we calibrated the model with real world data, epidemiological data, which reflects the effects of the current interventions, and we are also considering combination of other strategies such as active case finding and such as expert testing and the interventions to increase the patient compliance and so on. That's our future plan. Future plan. Yeah. Thank you.
Fantastic. Actually, I just had an idea. Do you want to stop sharing and then we can see each other a bit better? Stop sharing your slides.
Oh, okay. I will stop the sharing. Yes. Wait a minute.
That's nice.
Yeah.
Do feel free to put on your video if you like. It's more sociable, I think, if you do. Yeah. But I was more talking about the future other interventions. so much. So we might imagine there might be new drugs or new diagnostics, so there will be less TB in the future. Did you model a scenario where there'll be less TB in the future because of non-vaccine interventions in your baseline? Another base case, a more conservative base case. And what do you think that would do?
I think I think only the single intervention would not be enough to achieve the NTB strategy goal targets, and the combination of various strategies targeting different status of the natural history would be nice.
Okay.
And
sorry.
this depends.
I see that Mama Punde from South Africa has a question. Please go ahead, Mama Punde.
Thanks for the great presentation. I had a bit of a technical question. I think on I may have missed this, on your calibration, you used TB incidence and mortality data, and I was just wondering what the source was. Is it from WHO or from other modeling work that has estimated those?
Thank you for your question. Our calibration targets are both from the WHO statistics and the China's public health center. Public health, yes. The demographic data are from the UN's United Nations population projections. They are from these sources.
Thanks.
Gavin is also from South Africa.
Yeah, thanks for a great presentation. You showed the results of the clinical trial showing the efficacy of Vaccae for prevention of disease. Is this the same trial that theWHO presented at the Union conference last year? If you can maybe just share your slides again. You had a slide, you just flashed it up very briefly, showing efficacy of Vaccae. But was that for prevention of recurrence, or was that the prevention of disease day?
The prevention of the disease. I will
just put up your slides, and then I'll show you what I'm referring to.
Oh, okay. Wait a minute. I will share the screen.
And then I'll come to why I'm actually asking the question now.
Yeah.
You showed efficacy.
Yeah.
Yes. So this phase 3 trial, was this the one that was led by theWHO? I don't know how you pronounce the organization, but he led the phase 3 trial of Vaccae in China. And the reason why I'm raising this is that if it is the same trial, I think like 75% or even 80% of the TB that was identified was clinical TB, not bacteriologically confirmed. And although we think that, and that maybe constitutes subclinical TB, and if that is the case, it's likely to be less transmissible or infectious as bacteriologically confirmed TB. So did you include that in your modeling? There may be the transmissibility, and the fact that this was presenting largely subclinical TB rather than clinical TB?
Yes, that's a great question. Yes, well, when the clinic, I have contact with the PI of the clinical trial. He told me that when screening for the subjects for Vaccae vaccination, they indeed they found some active TB cases through the GST screening and through the GST and chest X-ray screening. So the program contributed to increase the case detection rate actually, but these results were not included in their vaccination in their clinical trial final reports because the trial focused on the Vaccae's protective efficacy. In our in this sense, the TST the screening the prerequisite screening where indeed is some sort of active case finding measures. I think so. But we also we did not include this effect in this study. This is also a limitation of our study because this will underestimated the effect of the whole program.
Great, thank you. Yeah, so it's the same trial I was thinking of. I see you've got a package insert there referenced. Do you know if that trial has been published at all? The results of that trial?
No, their results have not has not been published because they want to be published in a prestigious journal such as AEJM and Lancet, but in my personal point of view, it's hard, especially for the time because the time is not very updated. They said that they submitted during the COVID-19 pandemics, but those journals are mainly focused on manuscripts on COVID-19. So they wanted to last year they said they are submitting their manuscript, but I didn't hear from them after that.
Great, thank you very much.
Thank you, Gavin. Great questions, Martin, in the UK.
Hi, Richard. Thanks. Thanks a lot for the presentation. I'm a health economist, but I haven't got any experience of China. So I was interested to see that the standard cost effectiveness threshold you used was 100% of per capita GDP, and I was just wondering why you chose that, and if there's any guidance in China for what it seemed to be appropriate for the health service there.
Yes, we chose the WTP threshold according the WHO criteria 1 to 3 times. But we also consider that we admitted that the threshold might be a little high too high for the threshold. We also adopted the lower thresholds, which were proposed by the experts from Australia. They propose that a 0.63 time GDP may be a better threshold for the WTP.
Okay, so and how many of the results were robust at that threshold?
I think so sorry. I'm the data are not at hand. So maybe I will respond to this question later.
It's okay. I didn't look in the paper. I was just wondering. Thank you.
That's okay. If it's after the call,
thank you.
If it's after the call, Dr. Chin, you can just send it to me and I can send it on to marketing, or we could put it on the notes. We usually circulate what do we send? No, we could circulate it. Okay, any other questions? Small or big? Okay, related to Gavin's question, he mentioned subclinical TB, and this is it's a structural question about the model. I think there's been increasing evidence around the potential role of subclinical TB, its existence, and the fact that it might be important for transmission. And also there is some evidence that maybe TB or NTB infection is not lifelong, so you can self-cure. Have you considered incorporating those aspects of NTB natural history into your model, and what do you think they might do to your estimates?
You mean the drug resistant TB, right?
No, there might be a subclinical TB that is infectious but doesn't have any, is asymptomatic, which therefore contributes to transmission. Whether you think that's important, and whether you think the fact that people may cure themselves of NTB infection, whether you think that might be important.
Yes, asymptomatic TB is very hard to be identified.
Yes.
But I think they may be classified as a slow progressing TB, and the best in my personal view, it may be it may depends on the active case finding strategies to find these individuals and treat them, because also although they may be symptomatic, but they may be infectious at the same time. To stop the transmission, they are better to be identified and cured. Yeah.
Thank you. And on self-cure, I don't think you modeled cure of or loss of infection. Is that correct? And if so, if you do you think it might have affected your estimates if that's significant?
Uh, uh, I, I beg your pardon. What?
I think there are there's evidence that MTB infection, if you're infected with MTB, that doesn't last forever. But I think in your model, you assume it does. So once you're infected for life. Is that correct?
Yeah. Yes. That's correct.
Yes. I just wondered. So the evidence is not. I mean, the evidence is it's a reinterpretation of existing evidence, and there are people who believe it, and there are people who don't. But I was wondering if you thought, if you added self-cure to your model, whether you think it will make a difference to your estimates or not.
Yes, as I mentioned, the screening before the vaccination will help to identify more active TB cases, especially those without symptoms. And if we add this effect in our model, the benefit will be greater, I think.
Yeah. Okay. Yes. Thank you. So, any other questions? Otherwise, I'll ask a couple more. Okay. So, the model's fantastic, and I think you alluded to some of the ways you might be able to make it more useful for policy in the future. And I was wondering whether, if you were a structural suggestion and also an intervention suggestion, whether you were thinking of modeling other risk groups that you could potentially target that's beyond age. I think you have an age structure model, so you could target by age, but I was wondering whether there were other potential risk groups you could introduce into the model, and therefore you could target with the vaccines and explore its health benefits and cost effectiveness. And then further, I think you've mentioned this already, but I think you're going to do some modeling that looks at the interaction between other interventions. So maybe active case finding, maybe therapeutic TPT. Do you have any plans in that direction?
Yes. We plan to incorporate TPT ACF TPT into the vaccine vaccination strategy. The combined there are some kind of combination options. We want to choose the optimal one, optimal combination, and we also are interested in the regional differences across the country. So some provinces are high burden and some provinces are low burden. The strategies might be different also.
Very nice. Okay, so you're going subnational. You're applying the model to different areas of China.
Yes.
Really interesting. I can't wait to see the results. Okay, and I think I've got one final question, which is about on the kind of policy side of your work. So, I mean, I think it's a beautiful piece of work. I think it's really important and really shows the potential value of the vaccine you've got. I'm forever writing papers about the vaccines we might have, but you have the vaccine we have got, which is fabulous. So what's the policy impact been? Do you talk to government ministers? Have they cited your work? Are they using your results? How is the scale up of what is the Chinese government and the Chinese population doing with Vaccae? Are they using it Do we know how many vaccine doses have been given? How many people have been vaccinated with it? Do we know, outside the trial?
I haven't contacted the government authorities, but as I know, they are extend their preventive interventions among at current stage among the two high-risk populations, subpopulations. One is the HIV/TB population, and another is younger young children population. For the middle school, for the middle school students, and yes, the main two high risk population are on the way, and they also plan to as I know, they also plan to extend the preventive treatment to such as the medical staff, and the patients with diabetes, as I know.
Okay, so can I repeat back to you what I think you just said? They were targeting the vaccine at HIV positive population, young children, and they might have plans in the future to target it to medical staff and diabetes patients. Is that correct?
Yeah. Yes.
Okay. So when they're giving it to young children, is that alongside BCG, or how does that work?
Let me clarify. The young children they focus is not all the children, but the the middle school students who were maybe not we are no longer protected by BCG, such as those entering the middle school students, or the children, or the contact of TB patients. Those children are at high risk. Are they are. Yeah.
That makes a lot of sense. Yes, that makes a lot of sense. I understand. And do you have any information about how many people in China have been vaccinated with Vaccae? Do we have any idea about uptake?
The acceptability of the new vaccine is not widely enough. It is not wide enough. For as I know, some for example, some teachers from the middle school who were screened as LTBI. More of them will choose the Vaccae vaccination rather than the traditional TPT regime, because they think the vaccine may be convenient, maybe safer, and yeah.
Oh, that's very interesting. So people are choosing the vaccine over TPT.
Yes. The acceptability of TPT is very, very low in China.
Yeah, I think that's the same everywhere. That's that with the exception of maybe HIV infected individuals. So yeah. Okay. I mean,
yes.
Dr. Chin, sorry, any other questions? Anything that you've thought of along the way that might help Dr. Quinn in his future work, or occurred to you about the study? Okay, well, I mean, yeah, sorry, Dr. Chin.
Oh, thank you again for your invitation. It's my honor to be presenting, sharing our experience. I wish we could collaborate with the team of your team and other colleagues around the world. So we can share our study, share the experience of modeling and study design, and yeah, such as that.
Well, that would be that. I mean, I think that's a very welcomely timed request. We're just setting up a TB modelling analysis consortium discussion groups, and the first 3 groups that have been proposed are one on vaccines, one on AI and TB modelling, and one on early career researchers. So in the next month or so, we will set up those discussion groups. And yes, I'll be on there. The vaccine modelers here on the London School will be there. And I hope, Dr. Chin, you and your team will join that group. And then we can do exactly that.
Yes.
Talk as much TB vaccine modelling as we want.
Yes.
So
we are much.
Are you on the TB modelling analysis?
Yes, we are. It's our pleasure to join these discussion sections.
Good. You can, so email me if you're not on the newsletter. We can sign you up and make sure you and your students are on that group. That would be great.
Okay.
It was your pleasure to present, but it was actually our pleasure to listen. This is really important work, and if there's one thing I would suggest, it's maybe go chat with some government officials. Some of your colleagues must have some links to government, and it will be great that you can share this work with them directly and talk about how they might use it in China. It's really valuable work and really important work. So we can talk about that offline. Thank you very much indeed, everybody. It's been a real pleasure listening to you today. And I think, and do join the TVAC newsletter if you're not on it, and they will send you emails about that discussion group I've just mentioned, and also about other upcoming TB modelling presentations. I think we have about 1 a month, so you're welcome to join those as they come along. Okay, thank you very much.
Okay, thank you.
Good day. Bye for now.